Good morning, everyone. I want to wish everybody a happy St. Patty's Day today. I want to welcome you to Opioid Awareness and Narcan Administration. We're still waiting a few minutes for our presenter. Her name is Josie Dutch, and she will be joining us. I want to say thank you to SAMHSA for making this funding available. Sorry about the dog bark. The Great Plains Native Connections Program, the Great Plains HPOG program, and Great Plains EPI program, who all collaborated to make this available, make these training sessions available to you. So a few housekeeping items. We will be recording today's session, and it will be posted on our website. If you have questions, could you please post them in the question box, and we will get on the questions as they come in. Maddie and Brooke will be monitoring our Facebook Live sessions today. And I'll be posting some stuff in the chat for the survey and whatnot. Does anybody know if Josie's gotten on yet?
Yep, I've been on. I'm on.
Okay, great. Thank you. Well, Josie, I'm going to give a little introduction to you right here. Josie works as the Tribal Opioid Response Nurse Care Connector on the Siston-Wahpeton Reservation. The Tribal Opioid Response Project focuses to connect people who have been diagnosed with opioid use disorder to services that are safe, effective, evidence-based, and culturally appropriate. TOR also promotes awareness through community education. TOR is grant funded under SAMHSA. So Josie, I'm going to turn everything over to you.
Okay, I think I was trying to share and it said that you had stopped it. So let me see if I can do it now. Give me 1 second here. Can you see my screen? Hello?
Yes, we can see your screen.
And you guys can hear me okay?
Yes, we can.
Okay, so like Stacy had said, thank everybody for coming. I am the Tribal Opioid Response Nurse here in Sisseton, working also under a SAMHSA grant. We represent the Siston-Wahpeton Oyate tribal community here. We actually have 2 grants going right now. And so I've been able to train quite a few individuals, first responders, our tribal police, our casino security workers, our BIA can carry it, our city police and our county police can also carry it, and also different tribal programs that do home visiting, work with the youth. They've been trained too, and so I apologize if some of this you already know. I just made the PowerPoint kind of geared for everybody and anybody, and so bear with me. If you have questions, feel free to jump in. Any comments? I do like it to be interactive, so feel free to say things. It's kind of hard for me to always watch the chat, and so if somebody is monitoring the chat, you can just read it to me, or I can't always see it when I'm sharing my screen. So if you could help me out, that'd be great. Are there any questions before we get started?
Yeah, Josie, this is Stacy. Could we use the raise hand feature?
Possibly, let me see. Yes, I think, let me see if maybe I can move the chat over into the other box and then I can see it. I saw somebody just raise their hand. Okay, good. And audio is good on Facebook. Yeah, just interrupt me, Stacy, if somebody says something and I miss it, okay?
Great. Thank you, Josie.
So I usually like to get started with just a little bit of a discussion. If you want to, answer out loud, you can. Just think about it to yourself. Is anybody using prescription or non-prescription opioids? Have any of you ever used Narcan? Is it important to administer Narcan to overdose victims? How willing are you to use Narcan? And how important is it for first responders to use Narcan? I know some people think, oh, I'm not a first responder, but really if you're first on the scene or, whatever capacity you're in for your job, you might come across somebody that has overdosed or potentially is overdosing, and recognizing that right away is very important. And then administering Narcan, or even we've had instances where a patient said, I think you need to use Narcan to the ambulance crew, and then the ambulance crew administered it, and then we're able to save the patient that way. I think kind of being aware of what you're willing to do, kind of your own thoughts, think about how you feel right now, and then we can reevaluate at the end of the program and see if your view has changed a little bit, if your understanding has been impacted. Anybody want to interact with that or answer those questions? Or you could type them to any thoughts as we go. Just let me know. So I really like to kind of start with the basics. I used to just go straight into the Narcan training, and I feel like people kind of forgot the background to opioids, and that opioids are a unique use disorder, or a unique addiction, in the fact that they have medication long-term that they can use, and also the life-saving medication. And so the potential for overdose, but the death of an overdose is significantly higher than other drugs. And that's why it's just great that we have extra resources for opioid use disorder. So I'll just start with what are opioids? So opioids are naturally found in the opium of the poppy plant. Some opioid medications are made from this plant, while others are made by scientists in a lab. Opioids have been used for hundreds of years to treat pain, cough, and actually diarrhea originally. I don't think anybody would really prescribe it for diarrhea right now, but we all know opioids, they cause constipation, right? That's one of the biggest side effects. So it kind of made sense that that's what they used it for back in the day. So there are natural opioids. So that would be the opium, the morphine, the codeine. Those are all in their natural state, okay? So there's semi-synthetic opioids. So that would be the heroin, the hydromorphone, hydrocodone, oxycodone are some good examples of that. Usually the Tylenol is added to those. And then the fully synthetic opioids, that means they're all made in a lab or in a house or wherever. Fentanyl and methadone are all synthetic. And so the term opioid is often used as a synonym for opioid, but really that term opioid refers to those opioids that are derived right from that poppy plant, either natural or semi-synthetic. So we know the most commonly prescribed opioids are the oxycodone, hydrocodone, codeine, morphine. We're all kind of familiar with those. Sometimes I think people forget that it is an addiction because it's a prescribed medication. You get it from a doctor, it can't be bad, right? Heroin is also an opioid. That's not technically a medication. Fentanyl is a powerful prescription pain reliever. It's sometimes added to heroin by drug dealers, which causes doses so strong that people are dying from those overdoses. In our area, we have had overdose deaths. All of them have been related to fentanyl. We've had a number of patients, that have tested positive for fentanyl and didn't know they were taking it. So sometimes I do, kind of joke with my patients, like, you have to know your weed, man. They're adding things to everything, it seems like. And I know, especially right now with COVID, at least my patients, or my, the community that I deal with, they are kind of just using whatever is out there right now. I know they were saying they can't find Percocet, so they're using heroin. And that, to me, I was just like, what? Be using heroin? And it's just kind of like your own thoughts with that. Fentanyl is actually man-made, like we said, synthetic. It is 50 times, it can be 50 times more potent than heroin, and actually 100 times more potent than morphine. So I remember when I was first a nurse and I was like, oh yeah, morphine, we use that for our chest pains and our, traumas and, all the really painful stuff. And when I realized fentanyl could be 100 times more potent, that just is really, kind of puts it into perspective there. Pharmaceutically, we use all of them, to manage acute pain, chronic pain associated with advanced cancers, usually traumas, childbirth, those kind of things. Non-pharmaceutically, they're illicitly manufactured and it's often mixed, like I said, with other things without the user's knowledge. In order to increase the drug's effect, some of the street names for fentanyl are Apache, China Girl, Jackpot, Dance Fever, and TNT. Heroin especially is highly addictive. All of them are really highly addictive. And then that increases the risk for overdose and death. So nearly all people, it was found in one of the studies that I was looking at, that nearly all people that use heroin use at least one other drug. And then that also increases the chance of overdose as well. So there's tons of different names, Oxy, Perks, Vikes. I think I've learned new one like every other week since doing this. So around the area, I work really closely with the BIA investigators, and so that is kind of, I always say fun, but it sounds weird because it's, real life stuff, but it's so interesting. And so if you look on the left side of your screen there, that's about $40,000 worth of pills. Oxycodone 30 milligrams are extremely prevalent, especially in North Dakota and around other Indian reservations. People from out of state bring actually loads of pills. So this was a load that was intercepted by our investigator, and they sell for about $80 per pill. I feel like that has kind of gone up a little just because of COVID. And I know one patient had mentioned they have like a dealer tax where they give you 10 and they get to keep one, or, there's just different things that they do too. This load was actually brought from Detroit to a reservation that's about 3 hours from us here in Sisseton. Also, then on the right, you can kind of see this is actually a mixture of oxycodone and fentanyl. What this dealer was doing is they were actually pressing the fentanyl to look like morphine. And so if you look closely, the fentanyl is actually kind of green and they're like a little bit thinner. And then the real oxys are bluish and thicker. And I think, like I said, patients are just kind of using whatever. And so that mixing and that change in what's happening in the body is just so hard. And so how I explain it to people is, okay, think about, so when somebody uses meth, everything speeds up. So if you think about a truck is, or I should say, a bear is chasing you. So everything speeds up. So think about what happens in the body. Your heart rate goes up, your everything increases, right? And so opioids, on the other hand, are downers. Alcohol is also a downer. Think about what would happen to the body if everything goes down. So think about you're on a beach with the waves and it's so quiet and it's nice and everything just slows down and your breathing slows down and your gut slows down and your respirations, your pulse, everything goes down. And so our body always tries to maintain a homeostatic state. And so we try to keep kind of that normal level all the time. So if we're mixing, all of a sudden we give our body an up, or our body's okay, slow down. And then the next day we give it a downer and our body's like, oh, speed back up. And that's kind of where we get into that organ failure. And that's, really difficult on the body when they are mixing drugs and using different things there. Kind of makes sense? Any questions so far? I can't see the chat again. Okay, I don't see any. So I work with the youth. Lots of people, I feel, even our officers, they just kind of umbrella pills. Oh, they're using drugs. Oh, they're using pills. There are many different types of drugs. There are many different types of pills, different routes, different reactions. Opioids are actually measured in morphine milligram equivalents. So with help from one of the pharmacists here, I actually converted them into kitchen measurements. And so when I was working with, we did a scavenger hunt for the youth. And so if you see here the difference in the strengths, and so I feel like the different strengths really sorry, I was reading the chat. The different strengths is really important to understand, because I think, you think of codeine, 0.15 morphine milligram equivalent. It's kind of small, right? Overdose, would probably take a lot, okay? Morphine, like I said, I used to think that was super strong. That was, we use that, I felt like at the worst of the worst situations, that was our go-to, right? And actually oxycodone, which is the Percocet, is 1.5 morphine milligram equivalents, okay? And then you see how the fentanyl in the end is 7.2 morphine milligram equivalent. So I tell people, I'm like, okay, so think about I don't know if you guys are at lunch right now, or maybe you're done with lunch, but at supper tonight, if you can use a salt shaker and try to shake out 4 grains of salt, it's almost impossible, right? So that is the amount of fentanyl that you would need to overdose, just those 4 little grains. And so we know fentanyl is made in a lab or, in a house or whatever. And so how many times are we baking something and oops, we spill a little extra flour in, right? And so we don't know, what could be in there, or if they even know how to make it right. Or let's say in the house they made their fentanyl and then they made their meth, and so some was just transferred. Any little bit really can have the overdose potential here. Kind of a good visual there. Understand a little bit better the different strengths. It's important to know the strengths. It comes into play too when we talk about overdose, because the different strengths, can contribute to the tolerance, can contribute to, how much they're used to, what they're used to taking, what kind they're used to taking, if it's the first time, if it's the 72nd time, things like that. Okay, so we're gonna switch a little bit, and I'm just gonna go through what happens to the body a little bit, especially the brain. And so bear with me, because I know it's kind of a lot, but I promise it'll make more sense in a little bit. So is all stress bad? Anybody? Is all stress bad? No, right? The brain circuit is important for natural rewards. That's the way it's set up. That's why we listen to the same song 70 times in our car, or we want the same food all the time, right? Or example, when we're crossing the street and a truck is coming, that's how we get out of the way, right? If we didn't have a little bit of stressors, we'd just be like, okay, hit me, whatever. But, a test we want to do well helps us perform well. So a good amount of stress is good. That's what helps us keep going. We don't want that truck coming at us all the time, okay? Anything you do, use can go through. It can affect the heart, the lungs, gets into your DNA. It can even affect the brain. And so there's many different studies going on right now. I feel like we're just kind of at the brink of especially opioid use, but really all drug use. And so here, if you look at the brain of the non-drug user versus the drug user, do you see that just the differences in the gray brain matter, the dopamine kind of levels there? Sometimes when we say like the lights aren't on, like the lights really aren't on, like the dopamine isn't there. The changes are where the brain is wired is where it's going to fire. And so opioids can actually change the wiring. And so the effects on the brain can be extensive. The good news is that it can actually come back. And so what actually happens in the brain? So your brain is full of molecules called receptors. They receive signals from other parts of the body. Opioids attach to those receptors on nerve cells in the brain, spinal cord, other organs. This allows them to block pain message. So you're in pain, it's blocked, okay? The body has pain, but your brain isn't getting that message, okay? So this is why they're prescribed in serious illness and injury. Opioids attach to those receptors. They also cause a large amount of dopamine to be released in the pleasure centers of the brain. Dopamine is that chemical responsible for making us feel rewards, motivates our action. The dopamine release caused by opioids actually sends a rush of extreme pleasure and well-being throughout the body. Well, it doesn't sound terrible, does it? Okay, so why is that bad? Our brain remembers that feeling when we want more. So continued use of opioids causes an unnatural rise in the dopamine, and then that alters the connections between the brain cells, causing cravings. These are like deep and essential, just like we have that urge to eat, it's deep and essential just as that. Then on the other hand, stopping them abruptly, so that's why it's not recommended to like cold turkey anybody or just stop or just anything with opioids, because that causes a stress hormone release at a catastrophic level that actually causes the opposite. So then that leads to fewer receptors, loss of motivation, and decreased brain matter. So if you know anybody that has an opioid use disorder, a lot of times they're isolated. A lot of times they just aren't really motivated to do anything. And the good news is that all can come back in recovery, and we need that gray brain matter. We need those for decision making. And so when patients come and they really can't decide things and they can't think of anything else, that harm reduction approach is the most important, because they need time to their brain to adjust to not having that and to use, medication, different things like that. Our brains do have the power to change, rest, to undo that remapping. So with hard work and individualized treatment, addressing the whole individual, recovery is possible. Okay, so that was kind of a lot. Any questions so far? So I put some statistics in here. These are actually new. We just got these in January from the Avoid Opioid from the South Dakota Department of Health. And so drug-related deaths, again, opioids are among the top there. And I kind of feel like this is underestimated, because I know even in our area, not this past summer, but the summer before, we had 5 just ourselves. And so I don't know how everything's being reported. But, they are an 87% increase from 2010 to 2019. So, I mean, it just continues to go up. And with COVID and all of this stuff, I feel like, our numbers next year are going to continue to be high. I also included from the Great Plains, just the differences in white opioid deaths versus American Indian deaths. Again, on that same scale, everything is increasing there. I think this is important to remember too. I feel like I have so many patients that the typical, oh, I had no idea they were using kind of thing. It really, has no face and no kind of look. If you look on the top left, male and female, it's very similar, very similar. If you look at that, and then also if you look on the right side, every single age group is represented here. And so it really can affect anybody, any gender, any race, anything. I feel like nobody is safe. And then, we always talk about like opioid deaths. Well, we don't want everybody that overdoses doesn't die, right? And so, just the effects on hospitalizations is extensive too. And again, I think this is probably, underreported, because how many people don't seek help or don't go in, or, with the dispersal of Narcan and different things, we know people don't always come in, after that, and so it's not recorded. And so I just wanted to include this slide too, that, the hospitalization rate is high as well.
Josie, this is Stacy.
Yep.
Is there any indication as to, I'm assuming whenever people are given Narcan, that they, most of the time, emergency crews are called, notified, and they come. Can they refuse treatment? like to go in? Would that affect reporting and things like that, of that nature?
So, and that comes up. That was a great question, Stacey. So we'll get into that a little bit more, but technically, like, so for example, what I tell the security officers at the casino is you call the ambulance comes, they check them out. The ambulance sometimes will say, you know, we can't force them to go in, but if they kind of, you know, review things with them, and then just educating the patient, because remember, they're going to wake up really disoriented, and so they're not even going to really remember the overdose part. And so, you know, it's strongly encouraged that anybody that they use Narcan for has a medical evaluation. And so I know we can't force anybody to go in, but it's very strongly recommended that they go in, and I'll explain why. There's a re-overdose potential. And so we'll get into that in a little bit, okay?
Great, thank you.
So it really can be about life and death. When we talk about misuse, I always want to say opioids have their place. You know, we need them for end of life. We need them for childbirth. We need them for traumas. We need them for, you know, we need them. And I think where we kind of got into trouble is, I know if there's any nurses or healthcare people on, pain is the fifth vital sign, right? In the 1990, that was when it came out. And providers were actually being sued because they weren't treating people's pain. And so then we had, you know, the opioid people come in and say, hey, give these opioids. They're great. They're not, you know, there's no danger, prescribe these. And then that's kind of what contributed to the opioid crisis. But I just want to make sure that everybody knows opioids do have their place. They are important. So when we talk about misuse, we talk about taking your prescription in ways other than instructed. So taking more than prescribed, more than the prescribed dose, or taking it more often than you should. Also getting and using prescription pills from a friend or family member. I don't know how many times I've, you know, heard, oh, my Kushi gave me this, my auntie gave me this, and things like that. And, you know, so even if it is a real medical condition, really shouldn't get prescription pills from a friend or family member. They should have evaluation for themselves. Again, different bodies can be affected differently. That's why, you know, the provider is the best person to kind of decide if that's what you should take. Also, taking prescription drugs to get high would be considered misuse. And then mixing prescription opioids with alcohol or other drugs would be considered misuse. So breaking it down a little bit, almost all, I mean, I really need to figure it out, but I would say 80% or even higher of my patients have had some kind of medical condition that they were prescribed pain meds for, and that's kind of how it started. So they have, you know, there's some kind of exposure, there's trauma, there's medical, something like that leads to opioid use, either illegal or prescriptive. And then just knowing that there is help, identifying any underlying cause, usually there's an underlying cause, whether it is mental, you know, some kind of behavioral mental thing, or, you know, physical pain. There are available programs and assistance. The only thing that you can't recover from is death. And so keeping that in mind, you can't help when bad things happen, but you don't have to live there. There's choices, there's, you know, people around that want to help. And having, you know, even teaching the kids resilience, it's built over time. Learning to say no to friends, you know, finding something else to do, even if it's like the parents. I have quite a few youth that their parents use, and so then making a plan, like finding something else to do. And then also parents, you know, just spending more time with your kids, kind of building their capabilities, because they're probably gonna, you know, run into something. Monitoring, problem solving, kind of watching that impulse control, different things like that, and just kind of approaching it a little bit different. So I'll explain. So here, our tribal opioid response, we are an intensive care coordination for people diagnosed with opioid use disorder. So I assist the participants in their co-occurring conditions, do some information counseling, motivational interviewing, referrals. My office is actually located in IHS here, and so I'm very lucky to work closely with the providers here and can get them over to the clinic when they need that. And then some wraparound non-clinical support as well. Also under SAMHSA grant, we have some other deliverables, including this. This would be, like our community and workforce education. This would fall under that. And so I'm lucky enough to be able to kind of expand and help other people in just educating on opioids and kind of what goes along with that. So I just want to touch briefly on this. There's different things that we are trying to improve, like improve access to treatment and recovery services. That's forever a barrier, I think, for everybody I've ever talked to. Promoting the use of the overdose reversing drugs, strengthening our understanding of the crisis through, public health monitoring, developing safe, effective medication strategies for pain management, improve medications to treat people who are addicted to opioids, and advance better pain management practices. So we have medication-assisted treatment. So this is different than Narcan, okay? Medication-assisted treatment would be like insulin is for diabetes. So this is like the long-term treatment. It's an FDA-approved medication that we use. It comes it can come in a sublingual tablet. It can come in a film. There's actually a shot. So some other terms are Suboxone, Subutex, buprenorphine, Vivitrol. Those are other names for the medication-assisted treatment. So this is for somebody that would be on this long term. They take it every day. There is a 90%. If somebody stays on it for a year, they're 90% less likely to not relapse. So I think this is newer. This harm reduction approach, like I talked about, is something that people are catching on to. Providers actually have to have a special waiver, so the X waiver, to be able to prescribe this. So they do have extra training, and so we only have a few providers here that can actually prescribe this. We do use Subutex for the opioid pregnant patients here, yes. And we've actually had 2 babies born. Their moms were on Subutex and everything went very smoothly. And actually we can't leave out the dads. We had one dad, 2, so I guess technically 3 babies, 2 moms and 1 dad that, were all in our program that are successful, and they continue to be successful, and their kids, are kind of the reason why they're staying sober. And so that's great. Yes, we do use that here. We also want to use the medication-assisted treatment in conjunction with, their primary care, behavioral health, and counseling too. The question is, do we see misuse of these drugs? We do sometimes. I think the harm reduction view is really hard for some people to understand. And sometimes I think, in my mind, I think I'd rather have them use Suboxone than use heroin. We do different monitoring things, and we actually build upon. So this is usually how we start somebody. So when we start somebody on medication-assisted treatment, they come in, they have an assessment, different things, and then usually they come back in a week or even 3 days, just kind of depending on how they're doing. And then it kind of just builds upon that. So let's say they were doing really good for 2 weeks or for a week, then we would maybe expand them later into 2 weeks. Okay, then you come back in 2 weeks, see how you're going. And then maybe we can expand it to 4 weeks, and then, come back. And it's kind of just teaching the brain kind of that reward again, and kind of just retraining the brain. So the next question is, can you please explain why this is the best choice for a pregnant mother as opposed to Suboxone? So they're still working on that. So Subutex or Suboxone actually it's part opioid, part Narcan, part that long acting. So when I say Narcan Naloxone are interchangeable. Those are the same. It's the same drug. One's the trade name, one's the generic name. So Narcan Naloxone are the same thing. So when I use both terms, and I'm sorry about that. So the Suboxone has part naloxone. See how that has the same ending? Naloxone, Suboxone. So it's part buprenorphine, part naloxone or Narcan. So it kind of has that safety net in there. And so it's harder to overdose on because it has that long-acting Narcan in there, right? So the Subutex is strictly just opioid, just has the buprenorphine opioid in that. Okay, so with the thinking is with the naloxone, you can actually put the baby into withdrawal if, let's say, just the naloxone crosses the placenta, not the opioid. You know, the body is kind of an amazing thing. Things can be free flowing back and forth. And so they recommend, or it was originally recommended to use Subutex as opposed to Suboxone, because the Subutex is just opioid. And so there isn't kind of that withdrawal that's in there. Because the naloxone will make somebody, it'll kick the, I'll explain, it'll make a little bit more sense later. We can get back to that, but Subutex is preferred for pregnant women. And actually most recently, there has been moms on Suboxone that have been just fine too. And so I think pretty soon they will probably just say to use Suboxone for everybody, just because it does have that safety net in there. Good questions. Okay, so now kind of what we came here for. So the Narcan Naloxone. So I'm going to teach you guys how to do with the nasal spray, just because that's usually what people use. Just know in the hospitals and clinics, they do use the injectable kind. And you can get the injectable kind. It's kind of similar to an EpiPen. So this is a nasal medication that is used for the treatment of opioid emergency when an opioid overdose with signs of breathing problems and severe sleepiness or not being able to respond. So see how we would just use this in an emergency type of situation. So this is what it looks like. Anybody that's kind of gave or have used Flonase, similar. You hold it, you know, between your first two fingers and your thumb. You push on the plunger and it just gives a spray. So remember how I was talking about the opioids, the brain, the receptors for opioids. So here's a good example of what the opioid receptors would look like on the brain. Do you see how the opioid fits exactly on those receptors, blocks those messages from going here? Kind of makes sense. If there's too many receptors, then that's when the slowing and the stopping of the breathing happens. Okay. So how do you suppose Narcan works, or naloxone? Very similar. So the Narcan actually has a stronger affinity. So those receptors like the Narcan better. So the opioid receptors, the Narcan will actually kick the opioid off of those Narcan, or off of those opioid receptors. So then this allows the person to breathe again and reverses the overdose. So if you see, Narcan only works for 30 to 90 minutes. We know people that use opioids, their tolerance can play a factor, how much, how many times, kind of what they've been using, what else is in their system. Do you see how if the Narcan, once the Narcan stops working, it will be released off of those receptors? And do you see if there's opioids still hanging out in the body? Those opioids can actually sit on those receptors again. And so that's when the re-overdose would happen. If there was still opioid hanging out and then the Narcan wore off, the opioids could reattach. And so that's why with every box of naloxone or Narcan, there's 2 doses in there. Also, I usually say if the first dose didn't work and you kind of feel like it's an opioid thing, kind of reposition the head and then try the other nostril. There can be something in their nose, a booger or anything. And so even trying that other nostril will help. I also remind patients, or I guess officers, I should say, that they may have to use this on each other. And so there's a couple different scenarios where there was one reservation where an EMS worker came in contact with some fentanyl on scene and actually ended up passing away. They didn't figure out until later that he must have come in contact, it must have got on his skin or his hand or his arm or something on scene, and then he actually passed away. And then in Florida, there was a police officer that went for a routine traffic stop. The patient, so, you know, people are really resourceful. They think of different ways. Some people will keep like a bottle of water and they'll put whatever they have. If they get pulled over, they'll put whatever they have in the water and it'll dissolve. Well, this person in particular smashed up the fentanyl and then threw it into the air. And so when the officer put his head in the window, you know, he inhaled it. Then after the traffic stop, he called in, said he wasn't feeling well. He actually crashed into a tree, and somehow they figured it out and gave him Narcan, and he was able to live. And so I remind people, you know, you might have to use it on each other. Some of you might be involved in home visiting programs, could come in contact with it there. You just never know. And so even using it on each other could be a factor here. So I just have our, I'm not sure if all of you are from South Dakota, but I have our South Dakota laws in here. And so any drug related overdose, you're covered. They're called Good Samaritan laws. And so anybody that would be needing emergency assistance for a drug related overdose, this kind of includes all of the substances, any controlled substances. And then our tribe actually has its own Good Samaritan law. And there's the South Dakota statutes there. If you want a copy of this, I can send that out. And so basically, if you give Narcan in good faith, the patient or the person can't come back and sue you for that. So you're covered under the law here if you try to help out. So I have a lot of people that are like, oh, you know, how do I know if they're overdosing, that kind of thing. So if the person is not breathing or they're struggling to breathe, call out their name. We recommend doing the sternum rub. So if you just kind of make a fist with your hand and you rub your knuckles with the closed fist over their sternum, I promise you they're going to wake up. They don't like that. It's not a pleasant feeling. You know, looking around at the scene, you know, there can be different substances like pills, drugs, needles. I know when I was doing the training at our casino here, they, you know, kind of were joking, oh, they always say, oh, they're just drunk, especially the night shift. And so we talked about different things like, well, what if they don't have a drink in front of them? You know, there's different things that you notice that can kind of clue you in. And so we actually did different mock drills with them and kind of ran through some different things. They would also have slow absent breathing. They might be gasping or making like a snoring sound. It's a specific sound. So if you've ever heard it, you'll know it when you hear it. They'll have pinpoint pupils, really, really small. So think about, remember, opioids are downers. Let's say we're on the beach, it's really sunny, right? Our pupils will be really pinpoint. That really shouldn't, pupils typically aren't pinpoint all the time because they adjust to the light, right? So especially if somebody has their eyes closed and you open, you know, you can just look into their eyes. If they're already pinpoint, that's a bad sign because they would actually be dilated, right? Because there would be no light if their eyes were closed. So some of those little key signs there, they may have blue-gray lips and even their nails, and then making sure that emergency medical services have been called is important. People say, what if they're just high? What if they're just over-medicated? So the difference is you will be able to wake them up. They'll respond to that sternal rub. Their speech will be slurred, but they'll be able to say a few things. So just keep stimulating them, kind of watching them. The overdose is where they're not going to respond. They're not going to be talking. The breathing will be so slow you can't even hardly see it. May kind of sound like they're choking. And then this is where you would have to do the rescue breaths and naloxone. So remember, prior to medication administration, so you'd want to give it to the right patient. I promise nobody will probably just let you give them Narcan without them knowing. So you should always have the right patient. Right date, they do expire. Administer naloxone, we always want the person to lay on their back initially. So think about if somebody's overdosing or somebody is coding, I would say. We always want them on their back. If we had to do CPR, they have to be on their back. So for example, the casinos, if they're sitting in a chair, I always say, get them on the floor, get them on the back, that kind of thing. Remove the Narcan nasal spray from the box. You'll hold the applicator from the thumb or the thumb on the bottom and then your first and middle fingers on either side of the nozzle. You'd want to tip the person's head back. So think about the respiratory system. If you want it to get in, you have to kind of do the same kind of movement as the as you would with CPR, right? You have to have that airway open. And that's why if it didn't work and you kind of thought that they needed it, just reposition the head and then use the other nostril there, or the other nair. And then gently insert the tip into one nostril and gently push with the plunger. I'll show you a little video of it here in a second. So after administration, we continue the rescue breathing if they still need that. One ventilation every 5 seconds. After 3 to 5 minutes, if they still don't respond or they have slow or no breathing, you can administer another dose. So if the victim is breathing, but they're unresponsive, we always want to place them in the recovery position. And this is just because there is a vomiting risk. And so you would kneel beside them, you know, put the arm closest to you up. You can actually put the knee up and then gently roll them towards you and just kind of keep monitoring them as well. If you have to give it again or have to start CPR, you just want to roll them back on their back. But until EMS comes, you want them in the recovery position. So considerations to always remember: keeping the scene safe. So your safety is a top priority. Another thing that I really want to touch base on is people can actually wake up a little bit violently. They're going to remember using, they're not going to remember the overdose, so they're going to remember getting high as like their last thing. And especially like with our security officers, if it was at the casino or something like that, they're going to wake up and assume that it's the police. Okay, so they might be upset. I remember even the first time I gave Narcan, it was actually to a patient, a known opioid user. She had surgery, her pain wasn't controlled. I wasn't her nurse, but her nurse had come to me, couldn't wake her up. And so I actually got onto the bed because I was going to start CPR. And I gave her Narcan in her leg and she sat right up. Like I thought she was dead. I was totally freaked out, ready to do a code on her. And I gave her the Narcan in the leg. Again, it was the injectable kind, and she sat right up and she was completely confused, like, what the heck? And so just make sure that you know they can wake up suddenly and they're going to be a little bit disoriented. So make sure you're safe. Also the scene, you know, if you have gloves available, with your own Narcan kits, if you get them or have them, you know, keep gloves with them or keep gloves in your pocket. Make sure EMS has been dispatched. Like I said, you want them to be there and evaluate them. You want them to be checked out because of that overdose potential again, right? That opioid, if it's hanging out, it can attach again, and that's where you can kind of get into trouble. So if the patient doesn't respond or have a pulse, you'll want to start CPR along with the Narcan. If they're gasping, not breathing, you may have to do the rescue breathing. Naloxone, you can give it 1 to 3 minutes again. I know the other slide said 3 to 5 minutes, so we'll just say 3 minutes. Typically lasts 30 to 90 minutes. And so again, it just kind of depends on how much of it they got, what their tolerance is, what they've been using, all of those things. Okay, are there any questions so far? I am gonna pull up.
Josie, this is Stacy again. I hate to monopolize the question time, but
No.
I do have a question, and I hope I didn't miss it. But so if these kits come with 2 doses of Narcan, right?
Right.
And so did I miss how long you said between doses you should give?
It's about 3 minutes.
Okay. And so should you expect them to wake up between those doses? Or because I read something that said that they could like re-overdose if they've taken enough opioids.
Right. Yep. And that's because of like I was saying, that you know how the Narcan sits on those receptors. So once the Narcan's done working, it'll release off those receptors. And if there's still opioids hanging out in the body, those opioids will reattach to those receptors. And then that's when they would probably re-overdose. So our pharmacies here in Sisseton, and I do believe it's every pharmacy, you would want to check with your local pharmacy, but we have what's called a standing order. And so like at our IHS here, anybody eligible for IHS can come get Narcan, no questions asked. There'll be a little bit of training, and then they can have Narcan there. And then at our local pharmacy, I think it's around $80, I want to say, the last time I checked. And so it just kind of depends. And then I think the injectable is actually a little bit cheaper. And so if you felt comfortable doing that, you could do that. And so check with your local pharmacy. Good questions. Anything else? Okay, I'm just going to show a short little part of this video here, and then it just kind of shows how to administer it here. Hang on.
Medical Director for Red Lake Nation. I will now review the steps associated with administering naloxone nasal spray 4 milligram for the emergency reversal of opioid overdose. Step 1, lay the person on their back. Step 2, remove the Narcan nasal spray package from the box. Peel back the tab with the circle to open the package. Step 3, hold the Narcan nasal spray with your thumb on the bottom of the plunger and your first and middle fingers on either side of the nozzle. Step 4, tilt the person's head back and provide support under the neck with your hand. Gently insert the tip of the nozzle into one nostril until your fingers on either side of the nozzle are against the bottom of the person's nose. Step 5, press the plunger firmly to give the dose of Narcan nasal spray. Step 6, remove the Narcan nasal spray from the nostril after giving the dose. Step 7, get emergency help right away. Move the person to the recovery position. Watch the person closely. Repeat steps 2 through 6 using a new Narcan nasal spray every 2 to 3 minutes until the person responds or medical help is received. Step 8, put the
Okay, any questions with that? Kind of makes sense. Okay, so what else can we use for pain? So people still have pain, we still have to treat it somehow. So we actually adopted a comfort menu from the Brookings Health System. So like I said, opioids have their place. We should start them at a low dose and stop as soon as possible. But also there are other things that we can offer. And so I think sometimes people think, oh, I just need a medication. I need a medication to fix it. But I mean, there's a lot of things that feel better after even just taking a shower, simple things, right? And so you kind of think about that. So one of the questions is, if it doesn't work the first time, will you need a new spray for the other nostril? Or are there multiple doses? So in each box comes two of those little kits. So each time it's just a one-time use thing, not like a Flonase where you can keep using it. It's just a one-time use thing. So that's why there's 2 in there. Usually you would think that like your EMS would be there before you would, have to use more than 2. There's been times when you've had to use more. Usually it does work the first time if an opioid is involved. So remember, there has to be an opioid. Now we know that people, use different, like let's say their drug of choice is meth, but there wasn't meth, they used opioids, or fentanyl was mixed in with their weed or something like that. There has to be some kind of opioid in their body for the Narcan to work. Okay, if in doubt, like I said, if it doesn't work and you kind of are sure that's what it is, that's when I would just say to readjust their head, use the other nostril just in case they didn't get the first dose. Like I said, usually it does work the first time. And then let's say like one of our casinos is like 20 minutes away, and so it takes the ambulance a little bit of time to get there. And so like for them, that re-overdose could occur. So like what happened with them, their first one, it worked. The patient woke up, kind of wanted to leave, and then the Narcan kind of started to wear off as they were waiting for the ambulance, and so they had to give that other dose. Make sense? Another question is, if you have the injection, do you use it in the thigh or can you give multiple injections? Again, usually one just works. It's like an EpiPen, yes, in the thigh. Shouldn't need multiple injections. And like I said, if you prefer to have the injectable kind, they would give you more information at your pharmacy for that too. You can give multiple injections, yes, but you wouldn't want to give another injection unless that first one wore off. And again, that's entering the body, you know, pretty fast. That route is, if you think about that route, goes right in. And so again, they would need to be monitored, you know, medically, and they usually keep them for a couple hours just to make sure that re-overdose doesn't happen. Good questions. Oh, sorry, was there any questions on the comfort menu? Just different things you guys can have available or facilities can have, that kind of thing. Okay, so how to protect yourself, your family, and your community. I know we're kind of getting close to the time. We're finishing up here. I do have some questions that we usually go through in the training that we can just talk through after this. Thank you for your patience. Anyway, talking to your kids, tell your kids about how deadly opioids can be. Children who learn the risks of drugs at home are less likely to use drugs than those who don't. So surveys actually show that 2/3 of teens who misuse prescription painkillers actually got them from friends, family members, or acquaintances. I remember when the youth center first asked me to come out there, and I'm thinking, what am I going to do with these kids? You know, what am I going to say? I don't even really talk to my own kid about that. I do now, but you know, then I didn't really know what to say. And so I actually created, I used one of these, it was a PowerPoint that I had gotten from, I can't remember, but I turned it into a game. I called it the Candy versus Medicine game. And so what I did is I went through pictures. There's on a paper, there'd be 2 pictures. We actually turned it into a game. And so the kids could click on it, because with, you know, COVID, everything, people would take that, and I can actually, we could send that out through their Facebook page as well. So what they do is they would click on which one they thought was candy, and then the other one was medication. And so, you know, when meds are in a container, you know it's a med, right? But we've actually had instances where people are hiding opioids in their baby bag, or they're putting it in a candy wrapper. And so if a kid ever came across that, they wouldn't know. Or let's say on the floor, they came across a Skittle, or they thought it was a Skittle, but it was really a Motrin. They look really close. And so we turned that into a game. And so that kind of opened up the door to talk to kids about, you know, you know, what to do if you did come across something like that. We also did a game called Good Choice, Bad Choice. And so we read different scenarios off to the kids, and then they had to decide if that was a good choice or a bad choice. So for example, Bobby keeps her medications in her toy box. Is that a good choice or a bad choice? Those kind of things. And it's really worked well. And then with the teens, like I said, we went over the different strengths of things. And then that leads into safe medication storage. And so keeping opioids and actually all prescription medications in a secure place, counting them, monitoring them, ask, you know, the number of pills you have, lock them up, ask your friends, family members, and babysitters to do the same. I see somebody put the Dropbox or medication lock boxes in here. We also, through our tour, have purchased lock boxes as well, and are kind of doing a pilot project with that. And so that's really important too. We're trying to figure out what's the best way for people to kind of keep their medication safe. There also is a take back day. Thank you for posting that as well, Stacy. April 24th. And so prescription take back day, that leads into the next one, dispose of leftover prescription medications. If you have any unused prescription opioids at the end of your treatment, find, you know, here in our town, each of our pharmacies have them. And then also our hospital has the take back. There are also different things you can get where you mail them back. We have these little packets too that dissolve the medications at home, and then they can throw them away. So, you know, getting rid of those. Also talking to the doctor, discussing alternatives for pain relief. They may suggest other non-addictive medications or certain complementary or alternative treatments, such as acupuncture. That's actually being used as a first step now for chronic pain. And then not taking opioids with alcohol or other medications. So anything else that's a downer, like benzos, muscle relaxants, so like Xanax, Valium, Flexeril, any hypnotics, Ambien, Lunesta, any sleep meds, any other kind of downer kind of drugs. These drugs and substances can actually enhance the effects of each other. And so that can lead to dangerous intoxication and possible overdose. Asking for help. If you or your family members, know anybody misusing opioids or developing an addiction, don't hesitate to seek help from IHS, tribal health, behavioral health. Treatment options, including counseling and medication assistance, are available. Knowing what to do in an emergency situation or an overdose emergency. So hopefully all of you feel a little bit at least more comfortable in giving naloxone or Narcan if you came across a situation there. Always call 911 if you suspect somebody of experiencing an overdose. Okay, are there any more questions? None on Facebook? Okay, so usually when I do the training, I usually do it in person, especially for the first responder. And so I just included in here our questions just to kind of make sure that you have the understanding. And so if you want to type it in the chat, if you want to blurt out the answer, that's fine. So what is important when surveying the scene of an opioid overdose and determining if it is safe to enter? Anybody want to answer that? I promise you won't be graded on this. D, right, all of the above. Good. So what is naloxone used for? Question 2. Very good, A. So remember, there has to be some type of opioid involved. And so if they are using something else, if there's an opioid included in it, then the naloxone will work. It won't work if it's just meth, if it's just benzo, if it's just anything else. It has to have some kind of opioid. Remember, that list of opioids is very long. Typically it's the fentanyl that causes that overdose. So what are common signs and symptoms that indicate opioid overdose? Think about everything. Remember, opioids are downers, so everything slows down. So I know this is a lot of things. And so everything that slows down, unresponsive, intoxicated, those blue fingernails, skips our skin, our lips, the pinpoint pupils, decreased respirations, decreased heart rate, blood pressure, and then that risk of vomiting as well. So what are the age and weight limits for using naloxone? And I didn't cover it, so it must not be important. There actually is no age or weight limits. Obviously, caution is used in neonates. There's limited data for use in pregnancy. If in doubt, it is given sometimes in the hospital, that those kind of situations. And, you don't want somebody to die, if that's what you needed to use. So question number 5, just kind of wanted to remind everybody that they are different doses. Not that you really need to know. We taught you today how to use the Narcan nasal spray, and so that is 4 milligrams. Obviously, the injectable, you don't need as high of a dose because it's an injectable versus inhaled. So just the different routes there. That was just kind of a FYI thing. Again, this presentation was geared towards our area, and so we can obtain naloxone or Narcan with a standing order here at our IHS or our Lewis drug, and so it is available. Please check with your local pharmacy. I would assume you can get it with the standing order. If not, something to question and kind of raise the awareness there. How should you store your naloxone is the next question. again, I didn't really cover this because I'm not giving you any today. Controlled room temperature, protected from light. So the way it comes, it actually has a film over top of it. So if you leave it in the package in the box, you know, in South Dakota, we had all 4 seasons, I think, last week. And so, you know, in the car would not really work there. And so as long as you keep it in a controlled temperature, protected from light, our casino staff, they keep it in their lockers. And then in their med kits, our officers keep it on their belt usually. That kind of thing. Question 8, if a second dose of naloxone is needed, how long should you wait to administer the second dose after giving the first dose? You don't actually have to wait that long, 2 to 3 minutes if you know, if it's kind of partly working, or you know, it didn't really work, but you look in the nose and there was something obstructing the airway there, just reposition the head, give it into the other nair. So what position should we have the patient if they respond to the naloxone? Thank you for those answering. Yes, see, so we want them in the recovery position. And, you know, if somebody vomits and they're on their back, there's that chance for aspiration, so it could get into their lungs. So if we tip them on their side, as long as they're breathing, everything should be good. And then we kind of talk about the different steps again. I'll just give you the answers for that. So we always want to call 911, check for the signs of opioid overdose, support the breathing, administer naloxone, place in recovery position, repeat if necessary, and make sure they get emergency medical attention. If there's any questions, you can sure let me know. If you want to email me directly, I can give you any of the resources that we have. I saw somebody had asked for the Good Samaritan things.
I think they asked for your tribal
The codes.
the codes
Good
for the Good
Samaritan law?
Samaritan. Yeah.
Yes, if you email me here, josie.deitch@ihs.gov, I can get those sent to you. I did save the chat, so. And then I think Stacy has a Survey Monkey that she would like you to fill out.
I did. I put that in the chat. Josie, would it be possible that we could post your presentation on our Great Plains Tribal Opioid Response training page?
Yes, I think that would be okay.
Okay, so we'll get those posted. I don't mean to interrupt you or cut you off. Just a couple of announcements after you're through.
Yeah, I don't see any other questions. So thank you all for attending. I hope that you feel a little bit more confident in giving Narcan or naloxone, or at least start thinking about some things. If you have anything that you would like to ask me about individually, feel free to reach out. I usually am pretty quick about responding, and thank you all.
Thank you, Josie. That was a wonderful presentation. I learned so much today, as I'm sure everybody else did. I do want to, I did post in the chat that if you are a resident or tribal member from the Crow Creek Sioux tribe, because that's where this grant particularly focuses, is on the Haisapa area and on the Crow Creek Sioux tribe. You can receive a Narcan kit if you will contact me. We will get those. Also, if you're in the Haisapa or Rapid City area, just to let you know, our Oyate Health Center has those at the pharmacy, and you can go in and request one of those. Next week, we're going to have the growing negative impact to communities, family, and children, a resilience collaborative conversation with Tiffany Petro and Heather Boxrud. I want to thank all of you for participating today, and a special thank you to Josie for educating us today. If there's no other questions, then we can go ahead and end our recording. And we will also have this posted on our tribal opioid page. And I just want to mention that these training sessions each are eligible for CEUs. You do have to log in with your own Zoom account, or log into here with under your name. That's how we count attendance for that. So if you don't use your coworkers or your husbands or your friend, just go ahead and sign in under your own name. Thank you all very, very much.